Thank you for joining us, Mr. Mahlangu, and thank you for that reminder.
Can you share the hosting rights too?
Okay.
With me, yes. Just click my name there, then give me the rights too.
Thank you for the introductions, colleagues. I hope I'm not leaving anyone out. So for our last session, we were looking at non-opioid chronic pain management. For today's session, we are going to move to opioid prescription for chronic pain. And Mr. Sandile Mahlangu will be taking us through that presentation. Just a reminder, colleagues, that we should silence our gadgets and remain muted during the session unless we would like to communicate anything with the team. And that in situations where we want to maybe ask questions or make comments, we can use the raise of hand or use the chat box as per the norm. So at this time, I think Mr. Mahlangu can give us the presentation on opioid prescription for chronic pain. I don't know if you'll share from your side or should we share for you?
I think I will share it. Just in case I collapse, you will be able to continue.
Thank you.
Okay. I don't know if you can see it.
I think it's still loading.
You know, the SPTC company released a memo that our donkey for Africa has been affected by the sea. So I don't know. I'm still waiting for it too. How is it now?
Still blank on our side.
Okay. Magic.
Okay, it's clear now. It's showing.
It's here now. Okay. Give me a moment. I'm learning new things. The magic I'm seeing, I've never seen it before. I don't know how it is now.
It's perfect.
It's okay now.
Yeah.
Okay. Thank you so much, colleagues. I'm hoping you will get me. May I request that Messi, once I'm beginning to be startled or not, don't hesitate to stop me. I will try to be very short with this presentation. Actually, these days we are treating this short theme under pain management, pharmacological and non-pharmacological. We have covered in our previous presentations the basics of pain management, especially in palliative care. But since last session, we have then decided to look closer on chronic pain, which is one of the problems we are facing when we are taking care of our palliative care patients. And chronic pain is a serious issue. So we have been looking at it closer last time by Mr. Lukele on the issue of how best we can manage it non-pharmacologically. So today we will be looking at how do we deal then with opioids prescribing for people with chronic pain. And these are the people we normally say bracket are the people who are at high risk of opioid addiction, which is one of the terms, but we prefer to use the term opioid use disorders. So by completing this, we are looking to list the consideration for prescribing an opioid trial for the management of serious ill patients' chronic pain. and then weigh the risk and benefits of using opioids to manage chronic pain that has not been well controlled with non-pharmacologic and pharmacologic non-pharmaco opioid treatments. So last time Mr. Kele revealed to us on the non-pharmacologic interventions and pharmacologic, which are non-opioid treatments that we may use for chronic pain. And then today we are looking on the issue if then it has not worked. So there are different definitions we need to look around. Some of the definitions will be a repetition of what Mr. Kele said last time. But the reason we are repeating them today is because we need to emphasize how we then view this definition. The first one is to understand a serious illness, because when we're looking around this, we are talking about serious illnesses in palliative care. So, which entails any health condition that carries a high risk of mortality. And this serious illness that has high risk of mortality also has a possibility of decreasing the quality of life of that patient, and has a possibility of reducing daily function of that patient, and can cause excessive strains on the caregivers. So once these feature that diagnosis, then that condition, it's a serious illness. First of all, it must have high risk of mortality, which is we normally call it life-limiting illness, and then or life-threatening illness. And then once it reduces quality of life and there's an impact on daily function and on the caregiver, then that one is a serious illness. And most of the time when we are going to look around chronic pain management, we'll be rotating around quality of life and functioning. So we'll be looking around those issues because they are very critical in pain management. Then another one is chronic pain itself. Mr. Kele explained this one very well in our previous presentation, that in chronic pain, normally it's a brain disease. That's the simplest term to describe it. It's a brain disease and frequently limits life or work. So this one is associated with functional impairment, and it comes with depression and anxiety and substance use and a decrease of quality of life. That's chronic pain. Once it's chronic pain, you know this one is a brain disease. Mr. Kele touched issues of sensitivity last time and explained it very well. I may not go back again there. But then we need to know that it comes with functional impairment, and then it comes with depression, anxiety, and then substance use. And later, then you will discover that also it comes with quality of life depreciation. So that one will be then called, it's a chronic pain. Normally, it is well defined as a pain that will be there for 6 months or 3 months. Yes, 3 months. Once we have this pain for 3 months, then we will say this pain has been there for 3 months. Then we know when 12 weeks has elapsed, then we categorize it as chronic. But then it has to come with these issues. Another issue is that we need to understand opioid use disorder, which is very important to understand when we are dealing with chronic pain, which is also called a brain disease too. That is related to a substance used specific to opioids. So sometimes they call it a substance use disorder, which is then specific to. Actually, it is called a subset of substance use disorders, and it comes with altered brain chemistry and compulsive use of opioids. So you'll see this patient becoming so compulsive in need of opioids. So they come with different behaviors because it's a brain problem. So this is one of the common issues. You need to also understand that when you say a patient has an opioid use disorder, it's a brain problem. Actually, it's under substance use disorder, under psychiatric or mental illness problems. And then we have opioid misuse, which is also an issue when it comes to chronic pain management. So when we're talking of opioid misuse, one of the things I need to say is that opioid use disorder is not opioid misuse. So opioid misuse is taking opioids more than prescribed. You know, I prescribed you to take 20 milligram of morphine, BD, but you are taking 20 milligram of morphine, TID, or you are taking 4 hours, you are taking 6 times or 10 times in a day, that we are talking about opioid misuse. And then another term we use there, we call these concerning behaviors, we call them red flag behaviors, we call abnormal behaviors. Then we are taking this person is an opioid misuse. And then another one that we normally look here, it's deep prescribing. It's very important. You will see it now and then coming in our presentation when we talk about deep prescribing. A clinician supervised process of discontinuing medication. It's very important that when we are a facility that provides opioids, we need to be well aware how are we going to prescribe our people. How are we going to taper the opioids, because that one is very critical to avoid problems with opioids. So when I do this prescribing, it's only indicated to discontinue this medication, which is no longer beneficial to the patient. You know, we'll discover that the patient is taking morphine, but it's no longer beneficial to the patient. So we need to prescribe it. If it comes with non-opioid drug like diclofenac, people will be taking diclofenac more severely. So we will find that it's no longer beneficial, then we'll deprescribe the drug. Sometimes we do this process of prescribing when the risk are more than the benefit. This drug was supposed to be benefiting this patient, but because of kidney areas and there, when we were weighing and calculating the risk-benefit balance, we discovered that then it is not worth it. Then we will have to sit down. The goals of care will come to deprescribing the drug. So I will say those are the definitions we need to understand for today. Last time we presented that under this small sub-theme, we are under it, which is chronic pain management strategies. We said that last time we covered assessment, we covered how to build relationships, we covered how to use non-opioid therapies, and Mr. Mhlanti explained those very well in our presentation. I hope you can access them in our platform. But today, then we are looking at now, if then the non-opioid therapies are not effective, then we are covering that area for today. I think the last 2 sessions then will cover the prescribing and precautions on how best we can manage the opioids. So today we'll be looking, if the non-opioids are not working, how then do we go about prescribing the opioids? So this is the fact we need to know. All drugs have risk of harm. All of them. There is none that is not risk carrying. All of them, they have a risk of harm. But then this is the reality also concerning opioids. They have a unique set of risk compared to other drugs, the opioids. So with this unique set of risk, they require safe measures and universal implementation of the universal precautions, screening precautions. So anytime you are thinking of using an opioid, know very well that you are using an AK-47 that can kill somebody somewhere. The risks are unique and very high. So you need to put safety measures when you are doing that and implement the universal screening precautions. We will talk about them. And also, when you know that they have high risk, as we know, they have these problems, but we know then that even though they have this reality of risk, the goal of using the opioids is not to kill the people. It's not to make them experience these opioid use disorders, but we want to increase the functionality and decrease the risk of the opioids. Every time you are using your opioids, one of the indicators is working for you is when the function of the patient is increasing with decrease of the risk of the opioids. Then you can clap hands and say, yes, we are achieving. So then what does this mean? It means that opioid therapy risk-benefit calculations must be prepared per patient. You cannot then generalize it. You must be specific to the patient you are dealing with in front of you. So there are different factors then that will influence your risk-benefit calculations. So one of it is that the patient characteristics, the social, the medical, the history. How is my patient in front of me? Last time, Mr. Kelly talked about comprehensive assessment so that you can understand the characteristics of this patient. medical history and everything concerning this patient. What is it? Also, we look at the caregiving support. You see there, I've even put a hand on with a liquor there. You need to go those characters. Is this person having the history of substance use disorders? And then you also look at the caregiving support. Actually here, you are looking at the knowledge, the education that can be provided, and how efficient can the patient and the caregiver administer this drug I'm giving them safely. So then you have to establish caregiver support and also look at the function, if impact of previous pain medication management strategies. Before you go to an opioid, get the history of the previous pain medications, strategies that have been used. And Mr. Kelly emphasized last time that we need to focus on the pharmacological and non-opioid treatments. Then you need to know how far they've gone and what is the history. If there is a history of abuse in those drugs, you need to brace yourself when you're moving towards opioids. And also the issue of risk of opioid use disorder. You will find some people have abused codeine. Some people have used paracodeine abusively. Some have access to tramadol and abused it. There's a lot. Then you need also to check the risk of this person being at risk. Some are at risk of, they have been using other substances, abusing alcohol and other drugs. So you need to get opioid use disorder so you understand then now how safe it is. Will I achieve the benefits, or will I be putting my patient at high risk? So some of the common risk of opioids that we know that are there, one, it's false. People are taking opioids, their risk is false. So any person who's taking opioids might be at risk of false because might be sedated, then will collapse. Opioid use disorders, that's one of the risks. He might become an opioid use abuser, or he must develop an opioid use disorder. So you must know that risk is there. Depression is also there. That's why people who are under opioid, you need to screen them through depression so you might get it as early as possible. Motor vehicle accidents, some of them, they'll be taking the morphine or any opioid and then drive, so they might cause accidents. They need to know those things. Sometimes death itself. Some people will get depression and then they'll abuse those opioids and die. So the risk of developing an opioid disorder are the same as for patients with serious illnesses as they are for any patient. Not for people with serious illnesses only, but everyone is at risk of opioid use disorder. So we need to know that. So then what does this mean? It means that every time I'm in my hands, I have an opioid prescription, or I want to prescribe an opioid, I need to weigh or balance between the risk and the benefits of the therapy itself. So this therapy, the calculation for opioid therapy will be different for each patient. So I need to put it in the scale. And every patient must be considered for opioid therapy, should be assessed for risk of opioid use disorder. Every time you consider someone for an opioid therapy, do the assessment of opioid use disorder. So this might be the benefit of the opioid. It will reduce the pain, it will improve functionality and the ability to spend time with my family. So, okay, if this is the benefit for the opioid, then one. But then what are going to be the risk for this one? One, opioid use disorder, false accident, and may all cause mortality. So I will be balancing this. Which one weighs? And then if the other one outweighs the other, then I make a decision from there and communicate with the patient. Factors most correlated with opioid use disorder, these are the factors. If one or more of these factors is present, the patient should be considered higher than standard risk for opioid use disorder. I'm hoping that will be most covered, and these standards will be more clear in our next presentation when we're looking at the risk mitigation ways. So past history of opioid use disorder will lead to opioid use disorder. If this person has once abused or once has this disorder before, then we know she or he is at high risk of developing opioid use disorder. Current or past history of non-opioid substance use disorders. Most or some of patients this now in palliative care, they are taking alcohol and taking cigarette, or they are smoking. So some have even take extra drugs. Any patient who has a history of alcohol, whether it's current taking alcohol or has taken alcohol before, that one is a red flag. You need to know this person is a high risk of developing opioid use disorder. You need to be cautious. Any patient with issues of anxiety or trauma, any patient with certain mental health diagnoses like mood disorder, somatoform, those people with mental health, those patients, mood disorders, if the patient has a certain mental diagnosis, when you're initiating them to opioids, you need to be cautious. That's a risk, and it's a high one. If they are taking any psychiatric medication, so there are many of our clients who are taking psychiatric medication. Some are in depressant, some are taking different drugs. If they are taking cautious on how we initiate them into opioids, or if they are taking opioids, then we need to monitor them very closely for opioid use disorder. So any of these, one of these factors, once it's there in your patient, know very well that you have a high risk patient for them. But then the reason we are here and learning about this together today is because inadequate knowledge and education on our side is most of the problems that we have, and sometimes the stereotyping. Currently, we have a study that we have conducted, and it has revealed that we still have negative attitudes and stereotyping when it comes to pain medications, and sometimes also we also have a lack of knowledge and education concerning pain medication. Another issue that we are at risk of using, I don't know if they haven't yet done more studies concerning this, over-reliance on pain scales in clinical assessment. We rely more on pain scores other than doing the total concept of pain. That's why we need all social workers, the team approach. So we do comprehensive pain assessment, not relying on just pain scales and then tell that this is my reason I'm prescribing opioids because the patient is pain score 10. But then have you considered the other areas? So we rely mostly on pain scales other than the whole clinical assessment in totality. Sometimes then another issues are the low health intelligence. Our caregivers also, this one has been also revealed by our studies that the patients themselves, they don't know what is happening. They don't understand. Healthy-wise, they don't know what is happening. They lack education. And then the issues of geographical location. In our country, there are areas we once may see walking there 1.5 hours to reach a patient. So if you say then the patient must go get morphine, you find that one will become a challenge. And these factors will affect your decision when we are deciding to initiate an opioid. How will then access these drugs? Okay. Let me then go to the risks that are there for our patients when it comes to opioids. So patients from all populations, including cancer patients, should be assessed for substance use before prescribing opioids. Conduct a comprehensive pain and substance use risk assessment prior to starting an opioid trial. Always comprehensive pain assessment and substance use risk assessment. Sugati was time educated us on this, so we have it in our platform. The risk assessment is critical because the risk of developing an opioid use disorder cannot be predicted based on appearance. I look at sun dealers like this, that is his risk. There's no way. Family and personal history of substance use disorder or of illicit substance use are a risk factor for future substance. So any person who have done that, in a family history on that is very critical. Having taken a prescribed opioid in the past is not a risk factor for substance use disorder. I need to emphasize that. Have you taken morphine or any opioid before? Yes, it's not a risk because If the person was taking it very well, it's not a risk. So another thing that I want us to understand is that I'm not sure, because the country is moving a little bit slow in terms of CMIS. So we need to understand that we need to use this platform very well to monitor our patients who are on opioids. So it will help us. So we need to always standardize it. Actually, this is an international standard that check the national prescribing or monitoring database, so which is CMIS, to know if my patient has gone to Manzini Clinic, has gone to RFM, now she or is at hospice requesting for tramadol, then I will know this patient is already on high risk or is already a substance use disorder in terms of opioids. So there are different questions we can use to ask these patients when we are doing the risk assessment. So when we're assessing them for the developing opioid, you can ask them that, have you ever had a problem with opioid in the past? They will answer you, are you taking any medication for mental health? They will tell you. Have you ever had trouble with other prescribed or recreational substances, including alcohol? They will tell you. Have you been diagnosed with any of these mental health disorders, maybe personality, somatoform, I mentioned before, psychotic, mood, or anxiety? They will tell you. Then you will know. But any yes to any of these predictive factors should be considered a high risk for developing an opioid use disorder. And those patients must be closely monitored using the universal precautions, which will be covered in our next session, I believe so. So prescribing considerations. The bottom line, whenever there's a prescription to be made, is that as a healthcare workers or providers, especially us providing palliative care, we hold the responsibility for safe and effective relief of suffering. So we have to ensure that. So then when we are considering to prescribe, is that no symptoms or signs or tools can identify individuals who are no risk. There's no tool. So then it means that all patients, including those at risk for substance use disorders, still need to have pain and their pain managed. So assess everyone, screen everyone who's going to take these drugs. And even if you find them to be like that, to be users, please find a way on how to manage them. We will cover it in our next presentation. But for today, they deserve to be managed very well. And all patients must be assumed to have the risk of developing opioid use when exposed to opioids. Close communication and close monitoring are critically important for all patients on long-term opioid therapy. And especially these ones who are on long-term are the people who have chronic pain. So they need close communication and monitoring. We need to strengthen our communications. So then when we are prescribing, then you discover that, no, when I was weighing the benefits and the risk of this therapy, no, the benefits outweigh the risk. Then these are the considerations that you need to do. One, you need to use the best prescribing practices. Two, set opioid therapy. And three, titrate and monitor. But then I will just put this, I will not read everything here. This is what we have been covering for the past, since October. We have been looking around these topics. So we have already tried to cut across these best practices. So that they in our platform, we have uploaded the materials, they are there in our YouTube. But we need to also consider these best practices. They will help you when you follow these practices. And then another issue is to set an opioid therapy. So here I will emphasize one or two things here. One, there's what we discussed when we were starting the program, which is called goals of care discussion. The purpose is that every time we're in palliative care, we need to set clear functional goals for any therapy or any intervention. So even with this opioid therapy, set clear goals for opioid therapy. Patients have this idea that once they are in morphine, the pain will go away. It will never go away. But the opioids will reduce it to a bearable level, and the goals must be set together. And the patients and the family must understand that there is no way pain will be completely eliminated as long as there is a chronic or serious illness behind, unless it is healed. So we set those long goals, and they must be smart. One other thing we need to do is that we start slow and then we titrate as possible. And be ready to taper opioids if they don't help. If they are not working, let the patient understand that we will cut them down. And then another thing is that when you are starting slow, then we say when you are initiating patient on opioid, you start slow, so you titrate and then you monitor. So what we are doing is we're saying that you must use the universal precautions approach to, and this one is recommended by palliative care or pain experts. And another two, when we are doing titration and monitoring, is that monitor everyone. You cannot know who is at high risk based on clinical judgment alone. So you need to monitor everyone. So the universal precautions that are there, we will look at them in our next session. Is one of the universal precautions is the issue of regular visit. Normally, people are prescribed on morphine. They will come refill every month. Or if then this patient is an opioid used is on opioid substance use disorder, they will come more frequently for review. Maybe a week they come for review. So you monitor them close. But then if they are standard risk, then you will give them a month. They will come every month. Then you monitor them. You go through the same questions. Opioid treatment agreements, I've once went to Manzini Oncology. I'm happy Tandazi is here. There's this agreement that the patient sign when they will be initiated on chemo. It helps them know their responsibilities during the therapy. Also with the opioids, not all of the patients, maybe for those who will be on long term, then we need to give them this opioid treatment so they know what they are going to take. There's also another one that is urine drug testing. Also, this one must be based on the ethics. It's very expensive to do these things. So not all the patients and not all the time. It must be prescribed after it has been weighed based on benefit and risk on what it can do. Dr. Smetlane explained those things very well last time when he was presenting. Then prescription of drug monitoring programs. So here we are talking about the issues of CMIS. So we need to monitor these people very close on where are they taking the drugs and where they're doing. And then there's also what we talk in naloxone training and provision. We also educate our patient if then side effects came and overwhelm them, how will they administer naloxone and how it can be provided and where can they get it? I've mentioned that the universal precautions, then we'll unpack this in our next presentation. Then the takeaways that I have for us is that maybe if we can forget everything, let's just remember that opioid risk benefit calculation will be different for each patient. And given the prevalence of substance use disorder in the general population, especially in the country, people are abusing substances. All patients on or considering opioid therapy should undergo routine risk assessment for substance use disorder. Universal substance use risk assessment and CMIS is critical for monitoring if your client is obtaining opioids from other sources. And all patients and those at risk of substance use disorder still need to have their pain managed safely and effectively. The unconscious biases and desperate fears of causing harm among clinicians, I decrease the access to effective analgesia for the patient. So we need to be very cautious of this patient. Otherwise, thank you very much.
Thank you, Mr. Mashamu, for that insightful presentation. I'm not sure if you can still hear us. Mr. Mashamu. Mr. Mashamu, are you able to hear us? Okay, colleagues, whilst we are waiting for Mr. Mashamu, maybe I can make a few remarks or comments on the presentation. I was able to note some of the key things from Mr. Mashamu's presentation. So one of the most important things I noted is that all pain medication does carry the risk of harm. So which is why we really need to do the risk assessment. And having said that, it doesn't change that the goal is to increase the function of the client and actually reduce the risk of harm. So we should be mindful of the barriers, as he has mentioned that there are some barriers from the clinician side and there are some barriers from the client side, which actually kind of like hinder the effective pain management. I am not sure if we have any questions or comments or additions on the presentation. This would be the time to discuss such things, colleagues. We can use the raise of hand or the chat box to ask questions or make comments. In the absence of questions or comments, maybe we'll move to our case presentation for today. But in case we are leaving anyone out, we can still use the chat box to communicate. So we'll ask Sibongile Melane to actually give us a case presentation.
Thank you, Mercy. Good afternoon once again, colleagues. Our case today is a 74-year-old lady with a cancer of the breast, stage 4. Our concern, which is okay, our main problem here was that the main problem here was severe hip joint. I'm sorry, I'm trying to upload the case for you. But meantime, I'll be continuing giving you what I have here. But here, severe hip joint pain, and which is radiating to the sacral region. Client insists that curative can still help, yet she is on stage 4. Concerns were that client cannot pinpoint pain at this critical stage, still cannot go to advanced care planning due to her beliefs. The chief complaints were right hip pain, which is severe radiating to the back, and she also complained of neck pain. Comprehensive assessment, pain 1 was somatic, location, hip, and the lower back, pain intensity 4/5, the time is around the clock. The pain is chronic, movements aggravate pain, relieving factors there is none, functional impact of pain, unable to perform her daily living. Current analgesic, which is on strong opioids. The effect still is none. Physical assessment, respiratory, we found that she is hyperventilating, muscular skeletal, a severe hip joint relating to the lower brain. Documentary, there was sore on the right cheek and poor skin take. Physical assessment is well oriented, stable mentally, attentive, but later mood dropped, seemingly tried to pick up concentration later on. Social aspect assessment, she's not working, Education level, secondary. Social economic class, she's a middle class. She's widowed. Lifestyle habits, alcohol, but now she has stopped all that. Relative health condition, with those family members, there was none. Even the two sisters who were there next to her have got no relative health issue with that. Other social related information, she's well supported by daughter-in-law, a son, and two sisters. Spiritual aspect, she's a Christian. She gets partial support from the church members. The source of hope is her God. Medical surgical history. In August 2021, she had mastectomy done, and in September, she started receiving a chemo. Relevant medications she has previously, ferrous sulfate, doxycycline, and amoxicillin. Current medication is MST, which is BD, pyridoxine, nifedipine, omeprazole, and doxine 50 milligrams and disappointed. Advanced care planning, not yet done. It's the DNR and DNI. What that's not yet done, we haven't had time to go down sit with her. Living will, none. Advanced decision to refuse treatment, no. Healthcare proxy, no. But then at the moment, we still have to go down sit with her. At the same time, she has the relative to take care of her. Mental capacity assessed, yes. Comments or concerns, and to address above in the next visit. Okay, vital signs, temperature was 36 degrees centigrade, beyond blood pressure 77 over 65, heart 64, respiration is 24. She's an epoch 4. The symptoms ranges like pain was on 3, that was severe, dyspnea 1, anxiety 2, which is moderate, drowsiness was on 3, anorexia moderate, constipation was mild, poor morbidity severe. And let's go down to further care plan. We are planning for a follow-up, but then we've already done a televisit. But what we sensed is it was anger. And we're planning for pain management, and then maybe try and discuss the goal of care there, but then continue with the counseling and further discuss a date for advanced care planning. And then refer her to our social worker, whereby we still need her on top there, whereby we have to assess and again assist her on the pain, whereby we can assess it maybe better with our social worker. Thank you.
Thank you, Muni, for the presentation. For our 74-year-old CA breast stage 4 client, do we have any questions for Magasibongile or any comments on how the client can be better managed? Our 74-year-old client was breast cancer. Maybe I can go back up to the main problems and concerns whilst we wait for questions or comments. Okay, there's a hand from Cyprian.
Yeah, afternoon, colleagues. I just want to know the pain, the neck pain, the chief complaint, he says it's the neck pain together with the hip joint pain. So according to me, it's not associated to the breast cancer. So what could be the cause of the neck pain together with the hip joint pain? What do the doctors say?
Thank
Is it
you.
oversleeping? Is it over old age?
Thank you so much for the hip joint pain. She has a history of falling. At the same time, she's worried because it is radiating to the back, and she pinpoints it to the whole side of the back, and seemingly to even the other hip joint. So she's pinpointing it in a way that you really have to sit down and assess exactly where the pain is. With the neck pain, when she's on a wheelchair, she always tilts the head to the left side. So that's why we pick up that she will always complain of the neck pain.
Thank you, colleagues. Do we have any other questions?
My second question is, since it's breast cancer, I understand the experience with chemotherapy. Are we planning to do radiation? If yes, what's the benefit of this radiation in this plan? Because this is stage 4. Is it for the radiation? Is it for pain relief? Or because another thing I understand is taking chemo for palliative.
Thank you.
So, not planning to do radiation.
Thank you for the with that, I would say no, she's never on anything. She's now on bed that day. When you go to the current medication she has that endoxin 50 milligrams now. And to go back to your question, you asked why is the pain on the bone? Yes, she doesn't refer the pain much on the breast. No, she doesn't. She says the pains they are bearable, almost to a point that she's somehow compatible with it. But when you look at the temperature she's on this MST. So my worry too again is that is it helping with the heat of the bone pain? At the same time, we say when a patient is on MST, we rely on it, and we usually don't give something extra. Okay, please help me there, I think.
Thank you, Mbuni. I don't know if there's any additions or questions with regards to what has been discussed today. Is there anything that we want to add or ask about the case? Magatlamini.
Thank you very much, Mahlangu, for today's presentation, and thank you so much, Mnguni, for today's case. My first concern is on the concern that you said about the patient that she cannot pinpoint where exactly is the pain. And the second one, why is it that the patient cannot say that the pain is right here, or maybe it's the disease progression, whatever it is, that might make us to have difficulties in managing the pain. But then I can also see on current medication, there is MST that the patient is getting BD. Is that MST able to control the pain? What happens after the patient has taken the MST? Is the pain reduced, or are we able to control the pain or the symptoms and the other distressing symptoms that the patient is going through? Because I'm so much concerned, because you said initially, you said the patient cannot pinpoint where the pain is. that is also one concern that can put somebody who is taking care of a patient at that stage have so many difficulties. But then when you see that there is MST, after giving the patient the MST, then on your assessment of the pain control, what do you come up with? Is it able to control the pain that is unable to be pinpointed? Thank you very much.
Thank you so much, Ngozi. I think we'll get there with the problem of pain, because she says anything you advise her on, even the non-pharmacological interventions, she says, no, it's only for few minutes. No, it's only for few minutes. Your medication is only for, it's not controlling my pain. I think we are about to get there. And the first thing when you come across or get to her or get to visit her, she complains of, she just tells you, I want to walk. So you may find that the pain is not there around the hip or the back. The pain maybe is psychological, because she just almost cries when she says, I'm now unable to wash myself, they feed me, they're doing everything for me. And with the MST tablet form, I think the concentration was on the cancer, and it was supposed to be BD is a tablet, and you'll be surprised when you learn that even the caregiver now is giving a once it is in the evening. And when you ask why, because the tablet is supposed to be BD, she says no. When we give her, she just sleeps that in it. When you want to do something or give her something to eat, she's drowsy and sleeping. So they decided to give it in the evening. And at the same time, they gave her a 30 milligram tablet, and they said she was supposed to get a 10 milligram. Just then we find that she has a problem of even maybe breaking it, because the tablet is not stored. So she's got that problem. And I think you get there with the pain assessment. As you see, our future plans is the goal of care, and maybe go ahead and assess the pain and manage the bone pain. We get a chance to see it the next time. Thank you.
Thank you, Nguni. I'm not sure if you answered, Ngozi.
Yeah, I'm partly answered. I think I got lost somewhere. When was the patient visited, and when is our next visit? Looking at she's got so many needs, especially the pain control and the other distressing symptoms that need to be taken care of. When is our next visit?
Thank you, Ngozi. Our last visit, which was a televisit, was on Monday this week. When was it? I forget the date, but it's not written here, I suppose. It was on
14.
Monday this week, was 14. And I think we are supposed to visit her as early as maybe before the end of the week, seemingly she's for psychological pain to be able to maybe make a follow-up very soon. Yes,
For how long has she been on MST?
I think it's a discharge made from hospital. We found her with the prescription already.
Oh,
Yes,
okay.
when we got to her on the 1st of, she was already 3 weeks from admission.
Oh, okay. It means the MST has been prescribed for more than the 3 weeks.
But we found it 3 weeks.
I'm looking at it like maybe the MST is unable to control the pain. Maybe if we can arrange that, we take the patient to where the medication, the opioid was prescribed, so that we ensure that they prescribe that opioid, which will be able to control the pain and improve the quality of life of the patient.
Sure, Ngozi. Thank you for that.
Thank you very much.
Okay, colleagues, if anyone, thank you very much for your comments and questions. I think Maris Melane here will get to it as soon as possible. I don't know if there are other questions. I don't know if we are leaving anyone behind before we wrap up anything. Okay. Thank you so much, colleagues, for your participation for today. About the presentation for Mahlangu, we have comments from Trustee Mbata. Says narcotics and other drugs other drugs of abuse have a cross tolerance. That were the comment for our participants. And there was another comment from Tandazile. She says, thank you very much for the insightful presentation, Mr. Mahlangu. One gets to realize some key considerations with this regard when prescribing opioids. So every time we have this kind of presentation, there is something new that we are getting. We are learning every day. So thank you very much, colleagues. In the absence of our facilitator, she has to take care of something very fast. This marks the end of our today's presentation or today's session. Our next session will be on the 30th of August, and the topic will be the risk mitigation strategies for opioid prescribing. So there is a link that we put on the chat box. Please click on that feedback link so that you can do your own survey. So we can see where are we about these eco sessions. So click on that link and give us a very brief feedback. So thank you very much, colleagues. So we'll see you next time. Please invite more so that we can have a very effective presentation in the upcoming topics. Thank you very much, colleagues. Have a nice and beautiful day. Thank you.
Bye.